This video reviews the use of non-invasive cardiac output monitoring in the perioperative period with the Cheetah NICOM. This slide illustrates increasing morbidity on the y-axis when patients receive either too little or too much intravenous fluids in the perioperative period. When patients are hypovolemic, morbidity increases related to complications such as organ hypoperfusion, failure, or sepsis. At the other end of the spectrum, complications related to excessive perioperative fluid administration, including wound edema, ileus, pulmonary, and cardiac complications, with the extreme example of frank pulmonary edema. Our goal is to provide the right amount of fluid support at the right time, with increasing complex patient comorbidities, bowel preparations that may or may not dehydrate patients, and combination of anesthetic techniques. This goal can be very challenging. So why use perioperative cardiac monitoring? We know that our traditional monitors of heart rate, blood pressure, central venous pressure, and urine output, to name a few, are unable to identify patients with significant deficiencies in tissue perfusion and oxygenation. Deficiencies in tissue perfusion and oxygen delivery, if not corrected, are associated with increased perioperative morbidity and mortality. Excessive intravenous fluids are also associated with bad outcomes. Physicians' ability to predict whether fluids are beneficial or whether the cardiac output is high, medium, or low in critically ill patients with hypotension is no better than flipping a coin. The majority of published evidence supporting the use of perioperative cardiac output monitoring comes from the esophageal Doppler monitor. An esophageal probe is inserted into the lower portion of the esophagus to measure the blood flow in the aorta. The clinician must manipulate the probe to obtain measurements of stroke volume, from which the cardiac output is calculated. Measurements using the esophageal Doppler are generally obtained with the patient intubated and ventilated. Significant training is required, and the disposable single-use probe costs approximately $200. In the May 2014 ANA journal, T.J. Gann at Duke University reported that the Cheetah NICOM monitor was comparable to the esophageal Doppler when used for goal-directed fluid management. The UK National Institute of Clinical Excellence in 2011 stated that the esophageal Doppler monitor offers proven advantages for patients and the National Healthcare Service, and should be considered for patients undergoing major or high-risk surgery or for other surgical patients who may require invasive cardiovascular monitoring. The UK National Health Service estimated the potential cost savings realized with decreases in perioperative complications and length of stay equivalent to £800,000 a year. In North America, the U.S. Agency for Healthcare Research and Quality reviewed over 300 articles, grading the evidence supporting esophageal Doppler monitoring technology as strong, which is their highest level of evidence, and defined the evidence as convincing, and that it is unlikely that new evidence will lead to a change in this conclusion. They found that the evidence demonstrated that Doppler-guided fluid management results in a clinically significant reduction in major complications and total complications, as well as a reduction in length of hospital stay. Based on the AHRQ report, the Centers for Medicare and Medicaid Services determined that it would provide coverage for esophageal Doppler monitoring for cardiac output for ventilated patients in the ICU and operative patients with a need for intraoperative fluid optimization. T.J. Gann at Duke University used the esophageal Doppler monitor for goal-directed fluid management in patients having colorectal surgery. Goal-directed fluid management was just one part of a bundle of interventions used for these patients in their ERAS or Enhanced Recovery After Surgery program. With the ERAS bundle, they demonstrated significant reductions in morbidity, wound infections, and length of stay. Although impressive, it's important to remember that a bundle of interventions were used to achieve these results, and it's unclear how much these improvements are related to the esophageal Doppler-guided therapy. In the March 2014 Annals of Surgery, a systematic review included 4 meta-analyses and 1 published review of enhanced recovery programs for esophagectomy surgery. All documented fewer complications and reduced length of stay. Interestingly, 3 of the meta-analyses showed that patients with goal-directed fluid therapy actually received more fluids perioperatively compared to the controls. They concluded that perioperative fluid therapy is a crucial variable and that there is considerable high-level evidence, i.e. level 1+ evidence, to recommend its use in major abdominal surgery. T.J. Gann recently validated the NICOM monitor as equivalent to the esophageal monitor for goal-directed therapy in colorectal surgery. They found that the NICOM performs similarly to the esophageal Doppler in guiding goal-directed fluid therapy with no clinically significant differences in outcomes and offers increased ease of use as well as fewer missing data points. In September of 2013, the Ottawa Hospital approved the NICOM monitor for use in colorectal patients in our ERAS program and for patients undergoing an open emergency repair of a ruptured abdominal aortic aneurysm. To track our NICOM sensor use, the sensors were secured in our OR narcotic dispenser and required the clinician to sign out the sensor. The feedback from the anesthesiologist was that it was easy to set up and provided valuable or essential information in caring for their patients. Occasional savings were realized when the clinician decided that the information provided by the NICOM monitor allowed them to avoid using an arterial line, central line, or pulmonary artery catheter. So how does the NICOM work? The monitor uses 4 paired sensors positioned on the patient to create a thoracic box. The sensors pass a low amplitude current across the thorax to measure a phase shift in the frequency of this current. The phase shift in frequency in the current correlates with aortic blood flow. The monitor is able to measure the ventricular ejection time, and using the change in measured current frequency is able to calculate the stroke volume. By multiplying the stroke volume with the measured heart rate, the NICOM monitor is able to calculate the cardiac output. The experimental gold standard for measuring stroke volume is obtained by inserting an aortic probe. In this graph, the measured stroke volume, in red, from the aortic probe was compared to the stroke volume calculated by the NICOM monitor, shown in blue. The NICOM monitor was able to accurately track changes in stroke volume and cardiac output. In clinical medicine, the gold standard for measuring cardiac output is obtained by a pulmonary artery continuous cardiac output monitor. The NICOM monitor was clinically validated against the pulmonary artery catheter continuous cardiac output monitor with 65,000 paired measurements following cardiac surgery. The NICOM was able to rapidly track changes in cardiac output and track these changes 3 minutes faster than the PAC-CCO catheter. The precision of the NICOM monitor was actually better than that of the PAC-CCO catheter. Both the sensitivity and specificity of the NICOM was 93%. The following 3 slides were kindly provided by Dr. Paul Hurt, an anesthesiologist at Sloan Kettering Memorial Hospital in New York. This slide graphically illustrates the response to peritoneal insufflation with an abrupt and significant increase in the mean arterial pressure, accompanied by a biphasic drop in the cardiac index. These changes were first reported in the 1990s and are believed to result from the visceral tourniquet effect of insufflation and the absorption of carbon dioxide from the viscera. The next 2 slides are very busy. However, I will break down the information as they provide invaluable concepts as to why cardiac output monitoring is important in the perioperative period. This slide illustrates hemodynamic parameters captured during a laparoscopic esophagectomy procedure. The x-axis shows a time frame of over 4 hours. This data was collected with a NICOM monitor, but not used by the attending anesthesiologist, who was instructed to provide their usual anesthetic care. One of the identified anesthetic goals during the operation was to keep the mean arterial pressure during the surgery greater than 60. The mean arterial pressure is trended as a black line. The cardiac index was not reported to the anesthesiologist providing the care and is trended in red. The stroke volume variability index, or SVI, is trended in blue. The anesthesiologist was able to maintain the mean arterial pressure greater than 60 for over 95% of the operation. A normal cardiac index ranges from 2.5 to 4 liters per minute per meter squared. While the cardiac index is normal prior to the insufflation, there is a significant and prolonged reduction in the cardiac index for several hours during the operation. 40% of the time the cardiac index was less than 2, and 7% of the time it was critically low at less than 1.5. A stroke volume index of less than 30 has been used as a predictor that a patient is volume depleted and would respond to the administration of intravenous fluids with an increase in cardiac index. 60% of the time during the operation, the patient could have benefited from additional fluid administration. This third slide is again very busy and complex, but bear with me as I walk you through it. In this esophagectomy patient, the NICOM monitor was used by the anesthesiologist to direct therapy for both fluid and hemodynamic optimization. The 5-hour intraoperative data records the administration of fluids and vasopressors in the top of the slide. The goal was to keep the mean arterial pressure greater than 60. The mean arterial pressure is recorded as the red dots in the upper graph. The anesthesiologist also wanted to maintain a cardiac index of greater than 2.5 during the case. The cardiac index during the case is recorded as blue dots in the upper graph. With the use of the NICOM monitor, both a mean arterial pressure of greater than 60 and a cardiac index of greater than 2.5 was achieved for over 95% of the time during the surgery. As a sensitive measure of adequacy of overall tissue perfusion, the acid-base status was also monitored during the case. No significant base deficit or acidosis developed during the procedure. While there are many reasons for developing an acidosis and base deficit during a long operative procedure, the lack of a significant base deficit is essentially a good report card on the anesthesiologist's ability to meet the patient's tissue perfusion and oxygenation needs. The anesthesiologist was able to maintain a mean arterial pressure of greater than 60 for 95% of the time, whether or not they used the NICOM monitor. But the use of the NICOM data allowed the anesthesiologist to significantly reduce the time that the patient spent during the operation with an inadequate cardiac index or shock state. Interestingly, in these patients, when the NICOM was used to direct fluid and hemodynamic therapy, the intraoperative amount of fluid received was significantly less than the controls, perhaps suggesting that it is both the amount and timing of fluid administration that is important. The first case for discussion is that of a 67-year-old female who presented to our hospital with a ruptured abdominal aortic aneurysm. The patient arrived in the operating room with no palpable pulse and agonal respirations. The patient was intubated and resuscitation efforts, including an emergency laparotomy, was performed. For every 100 patients with a ruptured abdominal aortic aneurysm, only 50 of them will make it alive to the hospital. If they make it to the hospital, only 25 will survive to get to an operating room with a team equipped to deal with the problem. Of the 25 who make it to the OR, 9% will have an MI, 75% will develop renal insufficiency post-op, 15% will require dialysis, which is associated with a doubling of the length of stay in the ICU and a threefold increase in mortality. The average length of stay in the ICU is 9 days. Prolonged ventilation, pneumonia, and stroke are common associated complications, and the patient may require a repeat operation for bleeding or inadequate perfusion of the bowel or leg. The stats for repair of ruptured abdominal aortic aneurysms have remained unchanged for the last 30 years. The NICOM monitor was used in the OR for this patient and was absolutely crucial in guiding fluid resuscitation and vasoactive medication use in the OR. The patient was ventilated and sedated and taken to the ICU hemodynamically stable and not on any pressors. The NICOM allowed us to focus on patient care, and we were not distracted by the task of having to place a pulmonary artery catheter. She was extubated the next day and spent 3 days in the ICU. She developed postoperative delirium for 4 days, which may have been related to benzodiazepine withdrawal. However, she had no other complications. In a follow-up telephone call 3 weeks later, she was at home and able to carry out her normal activities of daily living. The surgical, nursing, and ICU teams were awesome in caring for this patient, and the use of the NICOM is just one part of the success story for this patient. So let's look at the cost of this patient having surgery. The cost of an arterial line is approximately $40. A central line is $60. The NICOM sensor electrodes are $129. Which is less than other non-invasive comparable monitors used for cardiac output monitoring, such as the esophageal Doppler, LITCO, or FlowTrack monitors. The estimated Canadian cost of treating a central line infection ranges from $9,000 to $29,000, with $18,000 being the average cost incurred. The cost of having to dialyze or ventilate a patient in the ICU is about $4,000 to $5,000 a day, and the cost of the surgical aortic graft bundle is just over $12,000. So for this patient, we achieved direct savings by not inserting a pulmonary artery catheter and theoretical savings by avoiding dialysis and prolonged ventilation. The NICOM sensors can be used postoperatively for up to 48 hours. So from a cost perspective, we are essentially cost neutral as a result of the savings from not inserting a pulmonary artery catheter and using a NICOM. In a theoretical conservative estimate, if we save 2 days of mechanical ventilation and 4 days in the ICU, this would translate to a savings of about $13,000, or the equivalent of 100 NICOM sensors. So when we look at new technology, let's plot the cost-benefit ratio on the y-axis and the patient surgical risk on the x-axis, with the y-axis ranging from no benefit to beneficial and the x-axis ranging from low risk to high risk. When the benefit of new technology offsets its associated cost, the benefit-cost ratio is 1 or neutral. We can imagine that for a range of surgical procedures and patient risk factors, at a certain point, the benefits of this technology exceed its costs. This is a purely hypothetical curve generated to depict the greatest benefits for new technology are likely to be realized for high-risk patients having major surgery. There is strong evidence from NICE, and AHRQ to support this technology for patients having colorectal surgery in an enhanced recovery program. For high-risk patients having major surgery, the benefits are likely to be even greater, and this is where we should be able to get the biggest bang for our buck. So the challenge is to identify high-risk patients having major surgery. Preoperative risk factors for patients having surgery have been previously identified, so we could theoretically assign a point system for each of these patient risk factors. We can also identify high-risk major surgical procedures, so we can recommend that the anesthesiologists consider using this technology when caring for these high-risk patients having major surgery. To ensure these sensors are used responsibly, we will continue to secure them in our operating room narcotic dispenser and require that they be signed out to individual clinicians.